we will take analysis of the chief complaint, and we will take also pain history as an example. Analysis of chief complaint, also called the presenting complaint, it is a description of the development of the illness. In analysis of chief complaint, you should use medical terms, but of course not when talking with the patient. I mean only when writing on your medical records. The first point in the analysis of chief complaint is the mode of onset. Is it sudden, acute, subacute, or gradual? Duration and frequency. Site of the symptom. Mention the site exactly, localized or diffuse. If diffuse, where is the maximum site? And don't forget to ask about where did it start. Aggravating factors and relieving factors. What makes symptoms worse and what makes them better? Let the patient talk about his aggravating factors. Do not put a checklist in front of the patient about the aggravating factors and relieving factors. You think that they are true about his case. Just let the Number 5 is the course of symptoms. Is it progressive or retrogressive? Progressive, the symptoms increase in intensity. Retrogressive is the opposite. Is it stationary or fluctuating? The fluctuating, that is progressive sometimes and retrogressive other times. Or is it constant or periodic, that comes and goes? Diurnal variations is found in many diseases like tuberculosis. Fever in tuberculosis has a specific time to peak, mainly at night. Seasonal variations is found, and you can find it in many respiratory conditions. Severity and the amount, is it mild? The severity is it mild, moderate, severe? Pain, let the patient describe the severity using a scale from 1 to 10. But do not describe the scale and do not give examples. Just let the patient give you a number from 1 to 10. Character of pain, we will talk about it later in this video. Vomiting, discharge are discussed later. Radiation, it's the extension of pain to another site while the initial pain persists. For example, the radiation of epigastric pain to the back in some patients with pancreatitis. This must be differentiated from referred pain. An example of a referred pain is an umbilical pain from the appendix. Associated symptoms, like the following 5 constitutional symptoms. The first one is fever, pyrexia. Ask about the grade. Normal body temperature varies from 36.5 to 37.2. So when we talk about fever, it's low fever if it's below 38.5. It's high fever if equals or more than 38.5. Ask about the character of fever. Is it continuous, the same level throughout the day? Remittent, that goes up and down but not reaching the baseline? Or is it intermittent? The fever goes up and down and reaching the baseline? Or is it relapsing? That's a fever with long intervals of fever-free periods. The second thing in the constitutional symptoms is the weight changes. Significant weight loss is more than 10% of the body weight within 6 months. Does the patient follow a specific diet to lose weight? And did the clothes become wider? Vomiting can be associated with weight loss. Now let's move to the appetite. Anorexia is loss of desire to eat. Anorexia should be differentiated from fear of eating, which can happen in gastritis or gastric peptic ulcer. The last 2 points is sweating and fatigability. Now let's go back to the analysis of chief complaint, and now the effects and impact of symptoms on the patient's life. The most important thing is the sleep and daily activity. Sleep, does the symptoms wake the patient up from sleep? And does the patient need an assistant? How many days the patient is off job or the school? Number 11 is the analysis and investigations done so far and their results. 12 is the response to treatment, if any. And lastly, the setting. You can ask the patient, where were you when you first felt ill? What were you doing? And who was with you? Now you can use these mnemonics to remember what to ask about in the analysis of chief complaint. You can include any important past medical, surgical, personal, or social history data which are strongly related to the chief complaint in the analysis of chief complaint. For example, you can include family history in a patient with a hereditary disease, the personal history of chronic heavy smoking in a patient presented with hemoptysis, past surgical history of splenectomy in a patient presented with sepsis. Summarizing the history of present illness, analysis of chief complaint, in front of the patient is very important. The summary gives the patient a chance to correct any mistakes in the history or any misunderstanding. Now let's take a quick example of the analysis of chief complaint. The patient was completely well 2 weeks back when he suddenly started complaining of severe breathlessness along with cough. The breathlessness is aggravated by dust and cold weather, with no obvious relieving factors. The cough is productive with green sputum and occurs approximately every 1 hour. Otherwise, his breathing is normal. This is the first occurrence of the symptoms, and he denies history of asthma. Always relay story in days before admission. For example, 1 week before admission, the patient so and so. For example, 1 week before admission, the patient started feeling the pain. Now let's move on to taking history of pain. Pain is an unpleasant sensation and it is a symptom. Tenderness is pain on touch, and it's a sign discovered by the doctor. The first thing in the analysis of pain is the site of pain. It's very important for making a diagnosis. For example, epigastric pain, chest pain, ankle pain. The onset, sudden, acute, subacute, gradual, and the duration. Some diseases have a pain of very short duration for seconds, like in trigeminal neuralgia. The pain lasts only for just few seconds. Many other diseases have a pain of much longer duration. If the pain is chronic and the patient was living with it, ask the patient what brought you to see the doctor. Frequency, periodicity, and time of occurrence. Pain of peptic ulcer is periodical and sometimes comes with seasonal intervals for a few weeks or months, on and off. Another example of the time of occurrence is headache. Headache that is more intense in the early morning can be sometimes an indicative of increased intracranial pressure. Now, the aggravating and relieving factors. Usually pain in the musculoskeletal system is aggravated by movement of the body part affected. Pain in some gastrointestinal tract diseases is aggravated by food. Some patients bend their trunks forward to relieve the pain of their pancreatitis. Also, alkali antacids relieve the pain of mild peptic ulcer. Severity of pain. To know the severity of pain, ask the patient about its interference with his daily life activity and sleep. Does the pain wake the patient up at night or stop him from going to sleep? Does the patient try to take analgesics? Can the patient give a rating from 1 to 10 explaining the severity of his pain? And remember, do not explain the rating. Now, the most important part of the analysis of pain is the character of pain. The character of pain is about how the pain is felt and how the patient describes his pain. The first one is burning pain, like in dysuria or inflamed urinary tract. And B is the dragging pain in organomegaly, like in splenomegaly or scrotal swelling. The patient feels as if the gravity dragging the swelling down. C is the stabbing pain, like the pain in peptic ulcer. The patient of peptic ulcer can point out the pain with one finger. Throbbing pain is a pain that comes in pulses. It's there when an abscess is found in the body. Tearing pain is like an aortic aneurysm rupture. Dull aching pain, the patient cannot describe this pain and usually say, "Just pain, doctor." That's the dull aching pain. Now, the colicky pain, it has two features. The first one, that is, it comes and goes in sinusoidal way. And the second thing, it's felt like migrating constriction in the wall of a hollow tube in an attempt to push the contents forward. It's more common when the gastrointestinal tract is involved. A constricting pain, also called crushing, tight, pressing pain, it might happen in angina. Distension pain, pain from an encircled organ that has a restricting capsule or wall, like the bladder or bowel, encapsulated tumor. And the last two are the pinprick pain in paresthesia and the boring pain in bone pain. It's noteworthy that chest tightness or heaviness is a term that could be used by the patient to describe a pain. That means it's a character of pain. And remember that pain in somatic nerve is well localized, while in visceral nerve it's diffuse. Now let's go back to the analysis of pain. Now the radiation. Radiation is feeling of pain in another area. This area is continuous with the area of maximum intensity of pain, while referred pain is feeling the pain in an area away from the area of maximum intensity of the pain. Number 8 is the associated symptoms. You can ask about the associated symptoms by the following question: did you notice anything else? Severe pain can be associated with pallor, sweating, vomiting, race in pulse rate. Migraine may be preceded by visual disturbance and vomiting. Course, just like any symptoms. And number 10 is the investigations done, responses to treatment if any, and impact on patient's life. Now, after completing the analysis of chief complaint, we will take a transitional statements before the review of systems. Prepare your patients for the coming questions by saying, "Now I'd like to ask you some questions about other parts of your body." Then begin the review of systems with an open-ended question, such as, "Do you have any other problems?" Thank you.